I'm Binita Patel, and I'm from Texas Children's. And as Dr. Vela noted, my interest in septic shock actually came through my interest in quality improvement. Our journey began in 2008, 2009, and today we're going to go through what I call septic shock and awe, and what really gets to the heart of improving septic shock care, which is minimizing unnecessary variation. So I'm going to start off with two stories. The first is of Johnny Jones. He was an 8-year-old with a lung transplant for pulmonary hypertension who presented with fever, decreased PO, cough, and vomiting. His initial triage vitals had a temperature of 103.2, a heart rate of 148, BP systolic of 111, and O2 sats of 91 to 93% on room air. A medical evaluation was called overhead, and a resident went to go evaluate the patient. Physical exam noted tachymucous membranes, some crackles in the lung, some perioral cyanosis, and was noted to be ill-appearing. In the emergency room, a normal saline bolus was ordered at 10 cc's per kilo. IV vancomycin was ordered, but it arrived 1 hour from when it was ordered. IV cefotax was ordered, and it was begun 2 hours after it was ordered, and then maintenance fluids were started. The patient was then admitted and transferred to the pulmonary inpatient unit, where upon arrival to the pulmonary unit, heart rate was 150, systolic blood pressure 88, and now the patient was on 2 liters of O2 with SATs of 97%. 3.5 hours after these vital signs were noted on the pulmonary unit, a rapid response team call was made for dyspnea, grunting, and decreased responsiveness. The patient went to the ICU, blood pressures were unattainable, additional fluids were given, 5 pressors titrated, intubated, and ECMO started. Johnny died 18 hours after presentation to our emergency room. This is what I call lack of awareness of badness. This patient was in septic shock and was not recognized. So now let's talk about Jenny Jones. She's a 7-year-old who presented with fever and respiratory symptoms. Initially had a temp of 100.1, heart rate of 186, systolic blood pressure of 97. She was seen by a resident. First bolus was ordered of 20 cc's per kilo over the normal routine of an hour. Vital signs continued to have a tachycardia of 192. The EC attending noted pneumonia, sepsis, needs ICU. Blood gas that was ordered initially came back about an hour or so later with a pH of 7.1 and a lactate of 7.1. Vital signs continued to have tachycardia. About an hour after the first bolus was ordered, it was finished, and a second bolus was ordered, again, over routine 1 hour. The PICU was called, said, okay, let's bring the kid up. 2 hours after the first and the second bolus were ordered, a third bolus was ordered. Again, routine over an hour. Around 5:45, SATs dropped and a 5-liter face mask was required. The patient was intubated, was taken from the EC to the PICU on high-frequency oscillator. Inotropes were started, and Jenny also died within 24 hours of presentation to our emergency room. And this represents a lack of timely interventions. These 2 cases represent the core of improving care for septic shock, early recognition and timely interventions. The goals of this talk will be to review the impact of sepsis on patient outcomes, to define the disease spectrum, to discuss early recognition challenges, and finally to review the evidence-based guidelines and the management of severe sepsis and septic shock. Let's go over some of the impact of sepsis on patient outcomes. Sepsis represents over 18 million cases worldwide each year. The annual incidence in the United States for severe sepsis is approximately 3 cases per 1,000. However, it's estimated that this is going to increase by 1.5% per year. And this is mostly due to the growing use of interventional procedures in our more vulnerable populations, such as our immunocompromised patients. And sepsis kills approximately 1,400 people worldwide every day. For pediatric sepsis, it is one of the leading causes of illness and death among U.S. children. Severe sepsis affects about 42,000 children in the US annually. The good news is that the mortality from sepsis has gone from nearly 100%, 97% in the 1960s, now to about 5 to 10%. However, 5 to 10% still represents a large portion of our kids. It's highest among infants and children with chronic medical problems. And sepsis represents 7 to 9% of all childhood deaths. The highest risk for sepsis, pediatric sepsis, are those with indwelling vascular catheters, children with short guts, with malignancies, and then solid organ transplant and malignancies. The most common organisms vary by the comorbidities. In previously healthy children, Staph aureus, pneumococcus, and meningococcus represent some of the most common bacterial causes, while in children with comorbidities, gram-negative, enterics, coag-negative staph, and Staph aureus lead the organisms. However, remember, many children with sepsis will have no organisms isolated, and many septic shock patients will actually have viral sepsis, and you may not be able to culture an organism. As far as resource utilization, severe sepsis represents the largest cost per patient and the length of stay. These numbers are back from the late 1990s, early 2000s. These numbers with our healthcare right now are much higher. So one of the keys to sepsis care is actually to define sepsis, to make sure that everyone is using the same definitions. And it's okay to call sepsis sepsis. It's okay to call it septic shock. I think we sometimes are hesitant to call it. However, if it clinically meets the definition, we should be calling it sepsis. So do any of these sound familiar? I know septic shock when I see it. That child doesn't appear septic. He looked so good, I didn't think he was septic. I thought her abnormal vital signs were just from fever. I don't need anyone to tell me what a child with septic shock looks like. They always look sick. His blood culture was negative. He wasn't septic. These are all common things that we hear that make defining sepsis hard. When you look at pediatric transports, this study was done in 2009, and they actually looked at transfers to a tertiary center. And what they found is that fewer patients were referred for shock than had shock, meaning they didn't call it shock, but when they presented to the tertiary center, they really did have septic shock. 37% were actually had shock, and only 7% were transferred with the diagnosis of shock. There is no gold standard for defining sepsis. Sepsis and septic shock are clinically diagnosed from physical exam, vital signs, and pertinent history. Lab and imaging studies help support the diagnosis, but the true diagnosis is made clinically. The Surviving Sepsis campaigns define sepsis as a range of clinical conditions caused by the body's systemic response to an infection. So we're going to go through the different spectrum, and sepsis is really a spectrum of diseases. The earlier you identify this spectrum and start interventions, the higher the outcomes, or the better the outcomes will be. If you wait till they get to septic shock, your morbidity, mortality increase dramatically. And unlike adults who present often with acute signs of septic shock, kids often present early on in the course and do not reach, have higher mortalities as they get to the septic shock range. The sepsis spectrum actually represents an intersection of infection and the systemic inflammatory response system of the body. And we're going to go through each of these things. And SIRS, which is systemic inflammatory response syndrome, for pediatrics has been modified. And the actual definition of it requires the presence of 2 of 4 criteria. And one of them has to be either a temperature abnormality or a leukocyte abnormality. The temperature, you must either have hypothermia or a elevated temperature, tachycardia greater than 2 standard deviations above the normal for age, Or in young children, they can actually present with bradycardia for children in less than 1 year of age. Respiratory, tachypnea greater than 2 standard deviations or requiring mechanical ventilation. And finally, a abnormality in the white cell count or bandemia. And again, to meet the SIRS definition, you have to have 2 of the 4 criteria, one of which has to be either a temperature abnormality or a white cell count abnormality. So when we go down the sepsis spectrum, what are some other key definitions? First, true sepsis is defined as meeting the SIRS criteria, 2 of the 4 criteria, in the presence of either a suspected or proven infection. Again, it's important to understand here that it says suspected infection. So you may not have your blood cultures back, you may not have all your laboratory exam findings, you may not have all your imaging studies back, but sepsis, if your suspicion is there and you've met the SIRS criteria, you've met the definition of sepsis. Severe sepsis is sepsis with one of the 2 following, either acute respiratory distress syndrome or 2 or more organ dysfunctions. And these organ dysfunctions represent either kidney dysfunction with elevated BUN creatinine, it could represent hepatic dysfunction with elevated bilirubin, you can have altered mental status or other neurologic findings, or you could have hematologic abnormalities such as low platelets. And finally, septic shock represents sepsis in addition to cardiovascular organ dysfunction. So what are some signs of cardiovascular dysfunction clinically? You can have altered mental status, and in young babies, it could just be unconsolable irritability or lack of interaction with parents appropriately. You can have abnormal capillary refill, you can have mottled, cooled extremities, abnormal pulse quality. One that we often ask about, but we need to keep in mind, is urine output, kidney function. And finally, hypotension. However, hypotension is a late finding in pediatric sepsis. A couple more definitions. So compensated septic shock can further be defined by compensated and decompensated shock. In compensated shock, there's signs of inadequate perfusion with a normal systolic blood pressure versus decompensated shock, where you have signs of inadequate perfusion, and now we actually do have hypotension. A couple more septic shock definitions. Cold shock versus warm shock. This is a little bit harder to define. I actually think patients present more in what I call lukewarm shock, meaning sometimes they have some of the symptoms for cold, sometimes a little bit of warm. And patients can go from one spectrum to the other spectrum. In general, in cold shock, you have cold extremities, delayed cap refill, and it really represents a state of myocardial dysfunction. You have a sick heart that's pumping against vasoconstriction. Versus in warm shock, you have warm extremities, flash cap refill, and it really represents a disease of vasomotor paralysis. You have a hyperdynamic heart with vasodilatation. I think in the adult population, you're more likely to see a little bit of warm shock versus in pediatric. They say that community-acquired infections typically present with cold shock versus children with indwelling catheters tend to present more with warm shock. However, again, most kids don't clearly identify themselves in one of these, and they often go from one type of shock to the other. And identifying which of these they're more aligned with helps determine which vasoactive agent ionotropes should be used first. Kids are different than adults. Compared with adults, children and neonates maintain higher vascular tone. And so in these kids, it takes a lot longer for them to get to the hypotensive state. They often present with tachycardia that lasts for hours and hours rather than presenting in hypotension, which adults often do. They often require more fluids than the typical adult. And again, hypotension is a late and ominous sign in children. The goal is to recognize and treat sepsis early in the continuum, when they're along the sepsis spectrum rather than the severe sepsis or septic shock. And sometimes this means just identifying them and watching them and making sure they're adequately fluid resuscitated. So what's the evidence and the guidelines for the care of children with sepsis? So back in 2002, the critical care guidelines came out that reviewed the care of patients with septic shock. It's been revised multiple times, re-released in 2013. It's been translated into multiple languages and is the basis for the PALS guideline. The biggest difference between the critical care guidelines and the PALS guidelines are really how fast they say fluid should be given. 60 cc's per kilo in 15 minutes for the critical care guidelines and 60 cc's per kilo in 60 minutes. I think PALS recognizes the difficulty in getting fluids into kids quickly, especially with the difficulty in getting vascular access sometimes. Rivers showed that if you followed goal-directed therapy, that you could decrease mortality, and adult mortality was reduced by 15% by following early goal-directed therapy. Hahn also showed similar findings in pediatric patients. For those that followed the critical care guidelines and PALS guidelines, for each hour of delay in instituting these guidelines, there was an associated 50% increase in odds of mortality. One of the keys to treating sepsis is early fluid resuscitation. And what we found is that fluid resuscitation is fluid sensitive, meaning the less fluids you give, your risk of mortality increases. So as more fluid was given in this population, the mortality decreased. And it was also time sensitive, meaning give fluids in a shorter period of time. So those patients that got fluids greater than 60 minutes had a higher mortality than those that received them in less than 30 minutes. And finally, from adult literature, early antibiotic use is also important. For every hour of delay in receiving the effective antibiotics, there was a 7.6% decrease in survival amongst patients with septic shock. So one of the things that over the last 3 years, the American Academy of Pediatrics has actually had a septic shock collaborative. They've taken the critical care guidelines and the PALS guidelines and consolidated the two into a clinical pathway. There's over 20 hospitals that are participating in the collaborative. And I'm going to walk through each of these steps for you guys. The key to this algorithm, as with any of the algorithms, is to recognize a problem and then to do something about it. In the first 20 minutes, the guidelines call for recognizing abnormal vital signs and altered mental status or perfusion. These are easy. These patients who present with florid signs of septic shock, everyone is in the room. You've got multiple nurses, multiple doctors. You're starting access. You're getting fluids. You're getting antibiotics. However, the reality is that kids truly present like this. They have a little bit of tachycardia. They're not feeling well. Their tummy hurts, but they relatively look well. In our institution, we call them pancake eaters because they are sitting there eating pancakes or they're eating their lunch. But in reality, they're on that SIRS, sepsis, septic shock spectrum. So how do you find these kids? Because these kids are hard to find. So one of the things that the Septic Shock Collaborative is utilizing is a tool to help identify kids who may be at risk. It doesn't mean that these kids are in septic shock, but it means that they have some abnormalities which require frequent reassessments and then to decide if this patient really does meet, from a clinical evaluation perspective, meet septic shock. So this algorithm looks at high-risk conditions, knowing that kids with underlying medical conditions such as malignancies, asplenia, indwelling catheters, severe CP, immunodeficiencies, we know that these kids are at higher risk. So let's identify them earlier. We look at abnormal vital signs, and then we assess their signs of perfusion to determine if they're at risk of having sepsis or septic shock. The vital signs are based on PALS guidelines and are age-specific, and look at heart rate, respiratory rate, blood pressure, and temperature. We know that kids come in with tachycardia all the time. When we look at our vital signs, it seems like kids have tachycardia. So how do you identify which of these kids have true sepsis versus the other numerous causes of tachycardia, like anemia, dehydration, pain, agitation, fussiness? Just being in a medical facility can cause tachycardia. What I say to that is difficult, and sometimes it requires reassessments, rechecking that heart rate after the temperature goes down, after giving Tylenol or ibuprofen. And one of the things I always say is, I hear sometimes, well, it's a hem-onc patient with a little bit of anemia, so they're going to be a little baseline tachycardia. Even in that patient, they can have sepsis or septic shock. And so although they can have other reasons for having tachycardia, you really have to use your clinical assessment and follow them through time to really determine if they have true septic shock. Assessment of the perfusion. It goes from looking at 4 key elements for perfusion, looks at pulses, the quality of central versus peripheral pulses, looks at capillary refill. What does the skin feel like? Is it cool and mottled, or is it flushed? Are there petechiae present? And finally, it looks at mental status. Are they awake, alert? Are they interactive? Are they appropriate, inappropriate? And after taking all of those things, high-risk condition, vital signs, and their abnormalities, we, as a group, have decided that the trigger will go off if the patient has either hypotension or they meet 3 of 8 criteria if they've got no underlying medical conditions, or they meet 2 of 8 criteria if they do have a underlying medical condition. And this really is trying to get at looking for signs of SIRS in addition to suspicion of an infection. And if they have those combinations, it doesn't mean that they're in septic shock, but it does mean that they may be on that spectrum, and a closer evaluation is needed. After the trigger tool is used, the next step is really doing your laboratory and radiographic evaluation if it needs to be done, administering oxygen, establishing IV access, and starting fluids and antibiotics, the do something about it spectrum. Given the oxygen demand and the metabolic demand of being in sepsis or septic shock, we do recommend patients be placed on O2. And if the patient is truly on the severe sepsis, septic shock end of the spectrum, we do recommend using early non-invasive ventilation like BiPAP, or sometimes even considering intubation to help offload the metabolic demand on the heart. If intubation is needed, recommend using ketamine as your sedative. Rapid IV access, as many peripheral IVs as you can. And remember that, and this is also difficult, we struggle with it, is that when you can't find that IV and you've got 4 nurses trying on each of the extremities and you've got your ultrasound fellow trying an ultrasound-guided IV, really the guidelines call for early access with an IO if you can't get IV access. Laboratories test. A blood culture is what is truly recommended and the necessary blood work. However, in general, we get CBCs, blood cultures, and lactate is becoming more and more routine in most sepsis, septic shock care. Its role is less clear. However, there have been one study that shows that if you've got a initial lactate greater than 4 in the setting of SIRS, that there may be an increased risk of having organ dysfunction within 24 hours. I think oftentimes the lactate is useful for our critical care colleagues who can then trend it to see how the patient is doing. Fluids should be administered rapidly, either with a pull-push system, a rapid infuser, or a pressure bag in 20 cc's per kilo aliquots, unless there's a suspicion of myocardial dysfunction. Begin broad-spectrum antibiotics within that first hour, and it should be institution-specific to what your resistant patterns are, typically gram-negative coverage in addition to some staff coverage. In the next 20 to 60 minutes, calls for continued fluid boluses, correcting any metabolic abnormalities like hypoglycemia or hypocalcemia. Additional fluids, again, in 20 cc per kilo aliquots rapidly. Go up to at least 60 cc's per kilo, and there have been children who require 100 to 200. Never gone up to 200 cc's per kilo, but I have gone up to 100 to 120, and that's not uncommon for kids to be very intravascularly depleted. The therapeutic goals of fluid resuscitation should be restoration of capillary refill, normal pulses, warm extremities. One thing, again, that we need to keep an eye on is urine output. If you're giving those fluids, you should have improvement in urine production, normal mentation, and a normal blood pressure for age. In greater than 60 minutes or at the 60-minute mark after you've done adequate fluid resuscitation, that's when you start considering starting ionotropes. Dopamine typically is started first, and then depending on whether you consider it warm shock or cold shock, progressing on to norepinephrine or epinephrine. And if the patient is on chronic steroids, to go ahead and give hydrocortisone. It's important to note that the peripheral dopamine, epinephrine, and norepinephrine can be given through a peripheral IV. I think sometimes we delay in giving these ionotropes because we don't have a central line. Central lines are difficult to get in an emergency room sometimes, especially if they're already intravascularly depleted. And so doing adequate fluid resuscitation, starting peripheral ionotropes, and then getting the patient to the correct resuscitative location, meaning an ICU. At greater than 60 minutes, this is where true goal-directed therapy takes place by putting in, measuring SVO2, doing treatments based on hemoglobin. Many of this is done in the ICU. We do some of this in our ER as we're waiting for ICU beds, but the goal should be to try to get them to an intensive care unit. So again, in summary, the goal of sepsis care is to recognize a problem and then to do something about it. And it's a spectrum, and the key to improving outcomes is to recognize it early and treat early in the spectrum. I'm going to go through our story at TCH. I've got a couple of minutes on how we've been at this for about 5 years now, and this kind of tells our story. We see about 80,000 EC visits per year, have 2,400 PICU admits. We have greater than 70 emergency department practitioners and greater than 20 PICU practitioners. When we asked, do you have standard protocols for resuscitation of septic shock patients, 50%, even though these guidelines came out way back in 2000, 2002, and knowledge of care of septic shock had been since the late 1990s, 50% of our staff said, no, we don't have standard protocols. And when we talked about, well, what is your performance? What is your mortality? How fast do you get fluids on board? How fast do you get antibiotics? We don't know because no one was actually measuring it. And what we found over and over again in morbidity, mortality conferences was a lack of awareness of subtle signs, lack of timely intervention, and system barriers. Our protocol and our quality improvement project actually started with a pediatric emergency medicine fellow who pounded his fist every M&M, saying we can do better. And we lived in a culture where oftentimes when mistakes happened, we pointed fingers, I hate you more, rather than actually getting at the root of the problem. And what we found is that every system is perfectly designed to get the results it gets, and a bad system will defeat a good person every time. Our aim was to create a protocol that looked at recognition and early initiation of goal-directed therapy. It was not to reprove the effectiveness of goal-directed therapy, and it was not to create a new standard of care. That had already been done. Our team was multidisciplinary with nursing, physicians, and interdepartmental. When we did our needs assessment, we found problems with recognition, resource recruitment, nursing procedures, poor communication, and lots of variation. And I bet if I asked this group, a lot of these would be similar in any institution that you go to. So some of our leverage points, what we wanted was patients to arrive, to get triage, many things to happen, and then they would leave our ER. We wanted to recognize badness early, to do something about it, and our protocol was established to fill that gap. We created a best practice alert. This is one of our first ones that we had that helped identify these kids from the beginning, from triage, and also had one in the back end for physicians. We recruited extra help with our transport team. We created standardized order sets, first in the paper world back in 2009, and then into Epic when we migrated. Initially, we actually had we created a paper form to help us with monitoring the progress and improving communication. We had minimized variation by having an established room that we always brought these kids back to. We standardized the interventions, how fluids were given. They no longer were able to be, fluids were not able to be put up over a pump, but had to be given via push-pull or rapid infuser. Pharmacy walked the antibiotics over. We created a rapid lab assessment protocol. So our results in that first year. This is a control chart. It's consecutive patients, and in the pre-protocol era, how you got treatment varied immensely, and not based on any individual patient characteristic, but based on the system. And then within that first year, we dropped our variation down, and we decreased our time to first bolus by half an hour. Our third bolus time also, we decreased it by 2 hours, and our first antibiotic by an hour and a half. Subsequent PDSA cycles over the last 3 years, we've experimented with dedicated rooms, dedicated nurses, dedicated ancillary support. We've gone through all boluses, regardless of whether they're being given for septic shock or gastro hypovolemia, be given rapidly, and we've gone through multiple versions of a best practice alert. Does it matter? So sustainability, we have been able to, over the course of the last 5 years, we're not there yet on what our goals should be, but we've been able to maintain our timeliness of interventions. Our mortality, I think it takes a while before we'll see a dramatic change, but our mortality has dropped. Our preliminary results show that back in 2008, 2009, when we started, mortality was anywhere from 10 to 12%, and recently looking at our mortality, it's down to 2 to 3%. We've decreased our length of stay in the ICU. Because we do early intervention with early fluid resuscitation, our ICUs have said that they've not had to put the central lines in because we've reversed the shock early on. So there's less use of central lines. We've decreased our use of pressors in the ICU, and we found that the use of dialysis amongst our ICU patients with sepsis has gone down because, again, we've done early resuscitation. And then from a family perspective, I have to say that this shock treatment was the most amazing ER experience we have ever had at TCH. As a parent of a child with a very long, complicated medical history, it is very comforting to know that my child will be treated so rapidly and effectively. The minutes or hours saved by this aggressive treatment could be the difference in my daughter avoiding a very serious illness or complications with her transplanted organs. And this is why we do our protocol. And again, I'm going to end with, I've used this slide multiple times because I think it is the key to providing good sepsis shock care, is to recognize that it is a spectrum, and morbidity, mortality is improved when it's identified early and interventions are started early. Questions? I think I kept it to 45.